Okay. So today our topic is calcium and calcitonin. Next Thursday we are going to talk in terms of syphilis. You'll be wondering why I put off all the topics syphilis, but syphilis is equally important. A little bit of STD. We'll take it from there. All right. So like I said, the topic is here in front of you. Calcium, calcitonin, and calcium. So let's go to the first slide. Okay. So calcitonin, maybe you guys know about it. So it's a hormone known to participate in calcium and phosphorus metabolism. In mammals, the major source of calcitonin is from the parafollicular or C cells in the thyroid gland, and is also synthesized in a wide variety of other tissues, including lung and intestinal tract. It acts to reduce blood calcium, opposing the effect of parathyroid hormone. You know that PTH is something that shoots it up in one direction. Calcitonin controls it. All right. So here we go. You've got the parathyroid gland. You've got the thyroid gland, and you've got the parathyroid hormone. Is one name. You can see the four glands on four sides. And we said, don't forget calcitonin. I can't read. It's part of the game. And over here on the cyclic picture, you can see, so if calcium level rises above set point, thyroid gland releases calcitonin, blood calcium level falls. That's the way it works. We go down to the cycle below. It says blood calcium level rises. No, we go from the other side. So if calcium level falls below the point, parathyroid gland releases parathyroid hormone PTH, and the calcium level increases. If you remember that vitamin D, etc., that we saw some months back, this was very, very well explained in that. Can I see the heading? So the heading here is what else does it do? More specifically, calcitonin lowers blood calcium levels in three ways. How does it do it? Inhibits calcium absorption by the intestine, inhibits also osteoclast activity in the bones, that is what triggers it, inhibits renal tubular cell reabsorption of calcium, allowing it to be secreted in the urine. However, effects of calcitonin that mirror those of PTH include the following. Inhibits phosphate reabsorption by the kidney tubules. We'll go further. Alright, so here is what is happening. We said that if calcium levels are too high, thyroid releases calcitonin, increases calcium deposition in the bones, depresses calcium intake in the intestine, decreases calcium reabsorption in the urine. So if the calcium level falls, this is what happens. Okay, and we've got, if calcium levels too low, you've got the parathyroid gland. So you've got the bone, the intestine, and the kidney coming into play to up the calcium levels. How does it do this? Bone, calcitonin suppresses reabsorption of bone by inhibiting the activity of osteoclasts, a cell type that digests bone matrix, releasing calcium and phosphorus into blood. The kidney, how does the kidney act? Calcium and phosphorus are prevented from being lost in urine by reabsorption by the tubules. Calcitonin inhibits tubular reabsorption of these two ions, leading to increased rates of their loss in urine. Very clear? So you've got the bone and the kidney coming into play. So here we said if calcium level is high, calcitonin into the act, inhibits calcium release from the bone, Uh, then if the calcium level in the blood is low, the parathyroid gland stimulates calcium release from the bone. So there's a compensatory sort of a mechanism going on depending on the calcium level. Thyroid again and the parathyroid playing a very, very important role. So difference in man and different species. There is a, I think yeah, that's fine. It seems clear that there are species differences in the importance of calcitonin as a factor affecting calcium homeostasis. In fish, rodents, and some domestic animals, calcitonin appears to play a significant role in calcium homeostasis. In humans, calcitonin has a major role in regulating blood concentrations of calcium. One interesting piece of evidence to support this statement is that humans with chronically increased medullary, where in this case medullary thyroid cancer, decreased in the case of surgical removal of thyroid gland, levels of calcitonin in blood usually do not show alterations from normal in serum calcium concentrations. So calcitonin playing a very, very important role in cancer of the thyroid. The most prominent factor controlling calcitonin secretion is the extracellular concentration of ionized calcium. Elevated blood levels strongly stimulate calcitonin secretion, and secretion is suppressed when calcium concentration falls below normal. So the compensatory mechanism is in play all the time as the body needs it. A number of other hormones that have been shown to stimulate calcitonin. Let's take a look. So you have hypocalcemia and hypercalcemia. So hypo prefix tells you less. Hypocalcemia refers to blood calcium level concentrations. Clinical signs of this disorder reflects increased neuromuscular excitability and include muscle spasms, tetany, and cardiac dysfunction. So this is what happens when your calcium is low. Hypercalcemia indicates a concentration of blood calcium higher than normal. Hyper, the prefix hyper. The normal concentration of calcium and phosphate in blood and extracellular fluid is near the saturation point. Elevations can lead to diffuse precipitation of calcium phosphate in tissues, leading to widespread organ dysfunction and damage. So I'll read it again. Normal concentration of calcium and phosphate in blood and the extracellular fluid is near the saturation point. Elevations can lead to diffuse precipitation of calcium phosphate in tissues, leading to widespread organ dysfunction and damage. Preventing hypocalcemia and hypercalcemia, there is a typo here, is largely the result of robust endocrine control. So we'll have to change that one, okay? All right, it's hypercalcemia, huh, guys? Capitals. Okay. All right, let's go to slide 11. So three major pools in the body of calcium. One is the intracellular calcium. A large majority of calcium within cells is sequestered in mitochondria and endoplasmic reticulum. Intracellular free calcium concentration fluctuates greatly from roughly 100 nanometers greater than 1 micrometer due to release from cellular stores or influx from extracellular fluid. These fluctuations are integral to calcium roles in intracellular signaling, enzyme activation, and muscle contraction. Who is in? Somebody came?
Yes, ma'am.
Took her in? What is that? Good. I'm concerned. Nazreen, okay, take her in. Nazreen's coming in. Alright. Alright, Nazreen, we are at slide 10, 11. If you can hear us.
Hello ma'am, good afternoon.
Good afternoon, good
Yes,
afternoon.
ma'am.
So you are
Yes,
all safe. I'm happy to report.
yes, yes, ma'am.
All three people from the Gulf are attending, so that makes me happy. All right. So we were talking of three major pools in body of calcium. The second is calcium in blood and extracellular fluid. Roughly half of calcium in blood is bound to proteins. The concentration of ionized calcium in this compartment is normally almost invariant at approximately 1 micrometer or 1000 times, 10,000 times the basal concentration of free calcium within the cells. Also, the concentration of phosphorus in blood is essentially identical to that of calcium. So there's a balance between the two. Bone calcium, a vast majority of body calcium is in bone. Within bone, 99% of calcium is tied up in the mineral phase, but the remaining 1% is in the pool that can rapidly exchange with extracellular calcium. So the body is such a marvelous place where this exchange takes place automatically and you and I don't even know it. Okay, so here we go. How it happens. Let's take a look at it. So you've got the parathyroid glands and how it controls calcium and phosphorus. You've got the bone playing a very important part. You've got the kidney. I think we saw this is individually. So increased calcium and phosphorus into serum, normally the range is restored. I told you there's a compensatory system. It's so beautiful. So increased calcium and phosphorus, and then you've got the compensatory mechanism taking place. Okay, phosphorus, what happens to it? As with calcium, the majority of body phosphate, approximately 85%, is present in the middle phase of the bone. The remainder of body phosphate is present in a variety of inorganic and organic compounds, distributed within both intracellular and extracellular compartments. Normal blood concentrations of phosphate are very similar to calcium. So we've got essential. What are the essential for? Strong bones, teeth, energy from food. You need your phosphorus for that. Okay. So fluxes of calcium and phosphate. Maintaining constant concentrations of calcium in blood requires frequent adjustments, which can be described as fluxes of calcium between blood and other body components. Three organs participate in supplying calcium to blood and removing it from blood whenever necessary. And that is your small intestine, the bone and the kidney. You saw it in the last cycle, in the last slide. Here you go. Take a look. You've got blood calcium and you've got the role of the bone. On the other side, you've got the intestine and you have got the kidney. So we come to hormonal control. Parathyroid hormone serves to increase blood concentrations of calcium. Mechanically, parathyroid hormone preserves blood calcium by several major effects. Vitamin D also acts to increase blood concentrations of calcium. It is generated through the activity of parathyroid hormone within the kidney. And if you remember that those lectures some months back, is very vividly explained. Far and away the most important effect of vitamin D is to facilitate the absorption of calcium from the small intestine. In concert with parathyroid hormone, vitamin D also enhances fluxes of calcium out of the bone. Calcitonin is a hormone that functions to reduce blood calcium levels. Keep that in mind. It is secreted in response to hypercalcemia and has at least two effects. There we go. So parathyroid hormone serves to increase blood concentrations of calcium, and we know that. Mechanically, parathyroid hormone preserves blood calcium by several major effects. I think you're repeating this. Vitamin D acts also to increase blood concentrations of calcium. This is generally through the activity of parathyroid hormone with kidney. Far and away the most important effect of vitamin D is to facilitate absorption of calcium from the small intestine. In concert with parathyroid hormone, vitamin D also enhances fluxes of calcium out of the bone. Calcitonin is a hormone that functions to reduce blood calcium levels. It is secreted in response to hypercalcemia and has two effects. This is what we want to see. So here we go, you've got your 25-OHD, that is your vitamin D, and the relation to parathyroid. So increased parathyroid hormone. Then you've got something that low vitamin D, decreased vitamin calcium. You've got supply calcium at the cost of the bone. So the body compensates whether it can from the bone, from the kidney, and from the intestine. Secondary, hyperparathyroidism, osteoporosis, bone pain, muscle weakness, fatigue, cardiovascular disease, immunological implants. So here you have the parathyroid hormone and you've got calcium in blood. See how it acts. So calcium acts on the parathyroid hormone. Parathyroid hormone then, by advantage of either kidney, the bone releases calcium, or from the kidney returns calcium, makes vitamin D3, and the intestine absorbs more calcium. So this, you remember, this metabolism is there in your vitamin D cycle that we went through some months back. Significance in two rare conditions: C-cell hyperplasia and medullary thyroid cancer. Excessive amounts of calcitonin are produced. I told you it becomes a marker. C-cell hyperplasia is a benign condition that may or may not progress to become medullary thyroid cancer. Medullary thyroid cancer is malignant. It can spread beyond the thyroid and can be difficult to treat if it is not discovered early. So keep that in mind, because I've had a case, a friend of mine, her husband, I think nearly a year back, had prostate cancer. And everything was out, it was done by robotic surgery. And he kept regularly in touch, took his PET scans and all. And then I'm talking a few months back, when the PET scan revealed something in the thyroid. And it was medullary thyroid. You know, the cell had traveled to the thyroid. So immediately again there was surgery performed at Rich Candy, and he got his thyroid off. And they got everything off. And the only effect, his wife laughed, is that he had a very nice, sexy voice. It took him some time. Still, it's been about 4 months, and I think my friend's husband is recovering from that voice problem, but he's perfectly okay. So you've got goiters. You've heard, when there's the bulging of the thyroid, and that's called goiters. So hyperplastic epithelium, Graves' iron deficiency problems, celluloid-filled follicles, antiplastic cells could be cancer. You said lymphocytes, then you got foreign body granulomas, and you got fibrous tissue. So I'm sure you've seen people with a very, very heavy thyroid gland called the goiter. So calcitonin levels may be elevated with lung, breast, and pancreatic cancers. See, I told you, in case of my friend's husband, it traveled from the prostate, and everything was removed robotically. And I think a year and a half later, we picked this up. Insulomas and rare pancreatic tumors called vipomas associated with vasoactive intestinal peptide, VIP hormone production. Vipomas. Concentration of calcitonin may be increased with drugs such as epinephrine, glucagon, and oral contraceptives, and are normally higher in newborns and in women during pregnancy. With medullary thyroid cancer and C-cell hyperplasia, other thyroid tests such as T3, T4, TSH are usually normal while calcitonin levels are elevated. So this is the comparison. And once it is detected, thyroidectomy is performed and the whole thyroid is taken off. And of course, this person has to monitor iodines. Your thyroid controls your iodine metabolism, and he has to be treated for what he had to undergo. So luckily, they are well off, and the treatment continues, and he's doing quite well. He's a very, very important lawyer in the High Court as well as the Supreme Court, and he's back to work. He got back to work within, I think, 10-15 days. The same thing after his prostate. It's very, very positive. On the other hand, I have a friend from Sophia. Unfortunately, we're very close. Her husband has POCD, and he's been in and out of hospital, but absolutely okay. He's a painter. In fact, some of the paintings in my house, you will see what my friend's husband has done. And every November or something, he has an exhibition in the house. And he just went for a checkup. He usually does because he's got a problem with the lungs. So when they took an X-ray of the lung, they found something there. So as usual, they said CT scan karao. CT scan was done, and the result was not exciting. So they said, now what do we do? So I was talking to his wife, and I said, might as well get one of the best people to look into this. And we did. And I was really missing my Anita Borges, because the guy who did look after him was Anita Borges' colleague. And I said to my friend, I said, I wish to God Anita was there to give us advice. And my friend also knows Anita very well. So I think on Friday they had an appointment with this gentleman. And he said, I knew what would be suggested. He says, surgery and chemo. My friend's husband says, no, I don't want anything. I'm perfectly okay. And he really is. He goes parks with his friends. He goes walking. He climbs up 3 stories. They don't have a lift in their house. And he has said, nothing. I'm going to live just like that. I'm absolutely all right. Only problem he has after we did the X-ray was he had a viral fever. So he was out for a couple of days. But after that, his wife tells me he's decided he doesn't want anything. So I think we have to pray to God that God looks after him. I told his wife, I said, go take a second opinion. I knew what the opinion would be, 99%. And we have a full stop. There's nothing that I can do. We are very good friends. We're very close. And he's such a talented art. I just told his wife, I said, do one thing. Since he paints, tell him not to do any painting right now. He also uses, he does a very beautiful pen drawings, pencil drawings. In fact, he gave me one for one of my book launches some years back. And I'm just hoping that this is not a full stop for him, and he can keep going on. But the diagnosis is not very good. And there's so much cancer. I have another friend of mine. Jyotsna was not with you guys, na? Jyotsna had a very dear friend, and she's come down. She went for a checkup 2 months back, cancer of the ovary, and had a complete hysterectomy done, and she's on chemo. She's maybe about 50 years old, 52 years old, and she's on chemo. I guess that's life. Somebody talking? Hanji? You know who I'm talking about? You know who I'm talking about? Jyotsna? Huh? You know who I'm talking about?
Yeah.
She was with you guys in Sophia?
Yeah, me and Joseph, we were like partners in crime.
I don't remember her. I don't know the girl. She just sent me some pictures. I've sent it to Ruzbeh for healing. I'll get back to him to see what he tells me. And sad. Jyotsna is here with her. I think tomorrow morning she flies back. Flies back tomorrow morning. I met her. They were down on Saturday. She and Ame, and we had lunch together because she was going for Dr. Vidya Doshi's son-in-law. You heard about that? Vidya Doshi's son-in-law. No.
No, I didn't. No, not
But
yet. No. I will call her.
52 years old and died. Sujata's husband. So there was a condolence meet at Radio Club.
No, no. Very young.
Huh?
Very young.
Very young.
Young.
Yeah. And the thing is, they both studied at Carnegie Mellon. They were working with Google in America. I don't know what made them come to Bangalore. They were working with Google in Bangalore. And then I think they were in Mumbai. They were staying in Virar or Vasai because Bharat Bhai had a flat there. And he was with Flipkart. That's life. Two children. It's sad. I don't remember this girl, huh? I don't remember Jyotsna's friend. I don't remember your class for that matter. That's life. Calcium, calcitonin. Shili, are you there? You're sleeping. Shili? Unmute.
Ma'am, I'm in the lab. I cannot speak. I can only hear.
Okay, ठीक है. They're not being bombed, na?
No, not now, but yeah, yesterday night. Day before yesterday night.
Rohaina is also here. She survived. Nazneen is also quite safe in Dubai, I think. They're here. Both of them are here. All right, guys. Nazneen, you're shaking your head. Sudayo. Tell me. Nazneen, I'm talking to you. Unmute.
Yes, ma'am.
How are you doing?
Hello, ma'am. Yes, ma'am.
Anything to add on calcium, calcitonin? हाँ जी बोल.
No, ma'am. It was perfect, ma'am. Calcium also regular testing only we are doing. Calcitonin also no new testing we are doing here. Regular.
Yeah, but the
regular testing.
significance of the test is important. Right?
Yes. Yes, ma'am. We are not doing any special test over here. Regular platforms only. Biochemistry platforms.
Cancer of thyroid का क्या कर रहे हैं आप? What do you do for cancer of thyroid? Nothing. You stop at calcitonin, is it?
Yes, ma'am.
There's nothing much you can do besides the MRI, isn't it?
Ma'am, in patients with hypothyroidism and hyperthyroidism, does the calcitonin levels change? Like, do you see any changes in the calcitonin levels?
You would show a little bit is shown, na. Calcitonin is usually related to calcium.
No, like in the suppose patients with hypothyroidism.
Hypo.
Hypo and hyper. Like those are values like you must be seen in the lab.
I can't comment on that. Shubha, what do you say?
I would say that you said in medullary cancer and in parafollicular cancers, you said that calcitonin is the only marker which helps us. And in that case, the T3 TSH is normal. T3 T4 TSH is normal.
Can we give it just tell you to repeat? So you got 25 also, 24, 25 also. No
But-
problem. You got 23 onwards. Yeah, last.
Shubha, she is asking कि hypothyroid and hyperthyroid.
Yeah.
So also do this.
That's what I want to tell you. In
Then
case of
our regular inside Janaki we are doing testing. So every week we have on our own testing practices. Like we refresher course on what we did in our college. Like this, आज है कैल्शियम और कैल्सिटोनिन का तो फिर पहले था आई डोंट नो फिर था पहले लास्ट वीक भी था एंटी सीसीपी एंड आरएस टेस्ट डिवीजन what is the test for what do we do what is the enhancement खाली 80 dirhams है वो बेचारी 1000 rupees चार्ज करती है but in that there is a series of 6 to 7 lectures combined like तो हर एक टेस्ट के ऊपर ये हमको ट्रेनिंग देते हैं and there is this is a doctor also like there is a doctor sitting.
No, but Parul, your question was hypo and hyper and calcitonin levels. What could they be?
See, I would tell that in case of hypothyroidism, the TSH level is high.
Right.
And in case of hyperthyroidism, the T3, T4 is more, and the TSH level
low.
is low. So, I don't think in case hypercalcemia, when there is a hypercalcemia, in this case, then only the calcitonin will come into play. Then only the calcitonin. Otherwise, if the calcium levels are normal, if one goes to a pathology lab for testing of thyroid function test, so hypo and hyper, but at the same time, if the calcium levels are normal, then why will the calcitonin come into play? Calcitonin will only come into play if calcium levels are high, or parathyroid hormone will come into play if calcium levels are low. So if the T3, T4, TSH is high or low, I think the doctor would also ask for the level of calcium. If the calcium levels are normal, in case of hypo or hyper, I think calcitonin levels will be absolutely okay as they are in the normal range.
So Parul, what ma'am is saying, and I agree, they're two separate things, they're two separate entities. In a way, they may be related, they may not be related. Am I right, Shubha?
Yes, means what I want to say, if there is a medullary cancer or parafollicular C-cell cancer, you said it is benign or it is malignant, and it may become malignant in future. But in that case only the calcitonin will be high, and it will be the marker which will detect medullary thyroid cancer. But if the calcium levels are normal, or if the calcium levels are low, calcium levels normal, high, then only the calcitonin will rise to bring these calcium levels down. If the calcium levels are low, then only the parathyroid would work to bring the calcium up. But in case if the calcium levels are normal, see, the doctor will ask you a battery of tests. He will ask you to do thyroid function test, he will ask you to do a CBC, he would ask you to do so many things along with the T3, T4, TSH. He may ask you to do a renal function test. But in case if the calcium in renal function test is normal, then why would they ask for a calcitonin? I think calcitonin will remain subtle, it will remain quiet. Only if the calcium levels in this case are high, then only the calcitonin would start working and it would bring the calcium level down. I think so.
I tend to agree with you on that score.
Thank you, ma'am.
Yeah, why it should means if you go to a doctor, he will also tell you to do a vitamin D, he will tell you to do vitamin B12. Like in case it will depend on your clinical symptoms, clinical sign or clinical well-being. in case if the renal function is absolutely okay, if your creatinine is normal, urea is normal, along with that if the alkaline phosphatase, calcium also is normal. In case if the calcium levels are high, then the calcitonin he would ask, and then the calcitonin will come into picture that it is high, or the parathyroid hormone will come into picture, the calcium is low. Now I can tell you, in case of multiple myeloma, this is something other than this parathyroid hormones. In case of multiple myeloma, the patient has sudden, means without any reason, bone fractures. Then in that case, the calcium is raised. The total proteins will be high. Like the normal range for total proteins is, it is between 8, it is between 6 to 8 or 8.4. But in case if the proteins, the total protein is 10 or 11 or 12, that would alert a physician, and if we ask them to do the ESR, then if you, the doctor would ask them to do X-ray, the X-ray of the skull, the pitting pictures in the X-ray of the skull. If the ESR is very, very high, if the calcium is high, then in that case, the doctor would ask to do the bone marrow also. He would ask to do a protein electrophoresis and for an M-band, and in that case, he would also ask to do a calcitonin. But the main reason for the raised levels of calcium is here due to bone breakdown, due to fractures. Yeah, then I think the calcitonin would be normal, but the doctor would calcitonin level then down. But then in that case, it will be normal. Why the calcium levels are high in this case? Because of the no reason bone fractures. So then the treatment would go in a different way. It will not be to bring down the calcitonin or work upon the parathyroid hormone, because the reason is totally different. And in that case, the patient has severe joint pains, severe bone pains, severe backbone pains, backache, and a fever, mild fever. Then in that case, the doctor would ask them to do a CBC, a LFT, or a renal function. Renal function would show creatinine is high. It would be somewhere like 2 to 2.4 to 3. Then in that case, calcium would be somewhere like 11, 12. But then in that case, the calcitonin would be normal, because the calcitonin is not the reason for the rise of calcium, is something else. The bone breakdown due to the reason for fractures, means no reason. The patient is okay. He didn't have a fall. He didn't have anything. But there is a bone fracture in the X-ray or in the CT scan. And then in that case, the leak of the calcium or the raise of calcium is due to the bone fracture. The ESR would be high. So in case of T3, T4, TSH, I think if the calcium is normal, but hyperthyroidism or hypothyroidism is there, if the calcium is high, then only the doctor would ask for a calcitonin. And then in that case, the calcitonin would be high, and the calcium is high, and then the parathyroid hormone will take the picture and bring down the calcium levels. So it is a beautiful interplay of the two glands. Beautiful interplay of the two glands. As you said that medullary cancer, or in the case of parafollicular cell cancer, then in that case the calcium is high, and then in that case the calcitonin would be high. But I think, if I am mistaken not, I will also do some reading and get back to you, ma'am. But I think the rise of calcium is due to bone fracture, unexplained bone fracture in multiple myeloma. So similarly here in thyroid, hypo or hyper, if the calcium is normal, then in that case there is no need of rise of calcitonin, or there is no unexplained calcium low levels, as you said, in the parathyroid hormones. They start working and they bring up the calcium in different ways, like bone resorption, That's what you said, that osteoclastic. There are two actions, osteoclastic activity and osteoblastic activity. Osteoclastic activity is those cell breakdown of cells. Osteoclast and osteoblast are the making up of the bones. So I think osteoporosis will be in, that is, you said bone matrix, the cells in the bone matrix, it would come down. So osteoclastic activity and osteoblastic activity. Osteoclastic activity will definitely go hand in hand with a raised calcitonin, as there will be lot of increased calcium in the blood, and the calcitonin will start working because there is lot of calcium in the circulation, and that will, the calcitonin will rise and it will bring down the calcium. So I think in T3, T4, TSH, or a hypo or a hyper thyroidism, I think the calcitonin will be normal only if there is a raised calcium due to some or the other reason. Sometimes this women or men who are senior citizens, they keep on taking calcium or they keep on taking vitamin B12 without routinely checking their calcium or without routinely checking their vitamin B12. As it is said that the menopause woman should take 1 gram of calcium every day. But at the same time, the diagnostic activity also should be there. Means you should go in for a regular pathological checkup to find out that everything is in proper state. The moment doctor sees something abnormal, the moment the doctor sees that the calcium levels are high, then in that case he will ask for calcitonin, and then if the calcitonin is high, then the treatment would start. This is up to my knowledge. Still, I will do some reading and get back to Dr. Modawala.
Ma'am, but wouldn't it be that if calcium is high, irrespective of whatever reason, it could be multiple myeloma or it could be hypo, calcitonin should be rising as a compensatory mechanism? Wouldn't that
compensate? I will have to read upon it. To be really frank.
Because I thought that if calcium is high, calcitonin will rise irrespective of what the reason is. Is that that was what I thought.
Yeah, it should rise, but I will have to read upon it. Okay. Without reading, I will not tell you anything. I think if the calcium is normal, then the calcitonin will be asked for. If the calcitonin is high, then in that case the doctor would do some treatment for it. I feel so. I will do some reading, and in the next lecture by madam, I will give her a short note that we will last lecture what was the problem and how we can tackle. Okay.
Parul, you are saying that it's a compensating mechanism, complementary mechanism. What are you talking about?
No, I'm saying when the calcium level rises, calcitonin will come in play to reduce it, right?
Calcitonin, calcium, PTH and calcium go together. Calcitonin, Shubha, calcitonin? I thought PTH controlled calcium, right?
That's what I'm saying, madam. Let me read something upon it in a different...
Even I'm confused about this, that if calcium level rises, calcitonin will come into play to reduce the...
Yeah, but then in that case, maybe calcitonin is raised. But despite of the work done by calcitonin, if the calcium is not coming down, because the three reasons for treatment for multiple myeloma or going into for a bone marrow checkup, the three things which are highlighted are: one is a raised calcium, the second one is the raised ESR, the third one is the pitting picture in the x-rays, and the fourth thing is unexplained highly raised ESR, and then also the protein leakage in the urine. Okay, so in that case maybe calcitonin will rise, but the calcium yet remains high. It will that interplay will not be taken into picture. The parathyroid glands, I think, despite of their action, there will be no action on calcium. I will read and I will get back to you, madam.
All right, I think
Okay.
that's interesting.
Thank you, ma'am.
Thank you for the
I will
explanation.
definitely, madam, I will get back to you. Dr. Mowdawala, I will get back to you.
Yeah, fine. We look forward to that.
Thank you, ma'am.
Yeah.
Okay.
Thank you.
I will do some reading and I will, because unnecessary, I cannot comment on it. Okay. I will definitely read about this interplay. It's a very good question. So that makes me read something. Okay. So I think I will have to find that.
We'll say goodbye because people have to get back to work. Some of you are already in the lab.
Thank
you very much.
ma'am.
Thank
for
you,
attending. God
ma'am.
bless.
Thank you, Dr. Shubhan.
Thank you, Dr.
See ya.
Shubhan.
Bye-bye.
Thank you, Dr. Shubhan.
Nazdin, you're okay with this? Chal, band karna, band karna, band karna. You're listening.